Thank you, Kalay. Thank you so much. And greetings from Delhi to everyone across. So just let me know when you can see my screen. I'm planning to share it. Okay. Is it visible? I hope my screen is visible to you guys. Yeah. Okay.
We
Right.
can see.
Yeah. Thank you. So basically, I think what I'm going to discuss is a very tricky case that we had to manage recently, and which actually told us that how little we know about COVID, and it's such an enigma. And as you all know, I mean, the last year was all about surviving COVID. We have learned a lot, but there is so much that remains unknown. So it's basically the SARS-CoV-2 virus binding to ACE2 receptors and leading to all its complication. And since the pulmonary manifestations are so overwhelming, we tend to underplay or tend to ignore rest of the manifestations. So basically, the GI complications or GI symptoms in COVID is seen in up to 15% of patients, and up to 6 to 10 will present with GI symptoms only. Now, one of the dreaded complication is mesenteric ischemia. Luckily, it is seen only in very critical patients who are in ICU and who had very severe or fulminant COVID-related disorders. In those, there have been case reports that these guys had some mesenteric ischemia leading to bowel necrosis and gangrene and leading to mortality. So the challenge we had to face in oncology was during the initial phase of COVID was how to manage these cancers during the COVID pandemic. And we being in Delhi were totally in the thick and thin of things of COVID. And so what we learned was that for all solid organ cancers which presented to us in resectable phase should be resected, irrespective of how our COVID scenario was. And the protocol that we were following to screen our patients was that we were doing RT-PCR within 7 days and then one within 48 hours, and also HRCT thorax to screen these patients for COVID to ensure the safety of the uh, people around and also the patient. So this is one case which I would like to bring to the notice of everyone around. So this gentleman, Mr. N, presented to us in July last year when we were actually in the midst of the most severe wave of COVID in Delhi. And he's a 59-year-old gentleman who is male, diabetic, and morbidly obese. His BMI was somewhere around 46. He presented with pain, abdomen, and weight loss for a month. All other parameters were normal. He did not have any LFT derangements. And ultrasound luckily picked up some hypoechoic lesion in the pancreas. And when he was further evaluated, CA99 was elevated. It was 512. And a CT scan was performed, which showed a lesion in the uncinate process of the pancreas. Luckily, it was a resectable disease. There was no venous involvement, no arterial involvement. There was no evidence of any distant metastasis. It was a straightforward resectable CA pancreas. As a protocol, patient underwent 2 RT-PCRs. The RT-PCR, which was done a day prior to surgery, was positive. So, but patient was totally asymptomatic, no symptoms related to COVID illness, and there was no abdominal manifestations as well. His inflammatory markers, including IL-6, D-dimer, and LDH, were also not elevated. So, the conventional wisdom at that time was that we're not going to operate in a COVID positive patient. We're going to wait till he becomes COVID negative. And what we were following at that time was a delay of about 10 to 14 days in these patients before we take them up for surgery once they turn COVID negative. So this patient waited for 14 days, rather 12 days. And when we were planning to operate him, since it was an uncinate process mass, and we thought it would be wise to re-image him. So at this time, this gentleman had no symptoms whatsoever. We just re-imaged him out of curiosity. what we found out was very striking. This was a complete mesenteric venous thrombosis. You can see these images. This is a Sag image in which there is a complete thrombosis of the mesenteric vein. Similarly here, if you can see that, it is going deep into the subsegmental branches, into the small branches. And luckily, this thrombus was not extending up into the portal vein. So we probably, just accidentally picked up this thrombus just out of imaging before it became symptomatic. Now we were caught in a catch-22 situation. We know that CA pancreas is a hypercoagulable state, and literature also tells us that COVID-19 is a hypercoagulable state too, because there is a lot of endothelitis and there is coagulation derangements. So possibly this is a COVID precipitated mesenteric vein thrombosis in a resectable pancreas, CA pancreas. So this was a PET scan which was done during that time, which also revealed the same thing. This is a pancreatic tumor here, which is intensely FDG avid, and you can see on an axial scan there is a non-occlusive thrombus in the mesenteric vein in this particular scan. Now, basically, at this point of time, operating him was not a good idea at all, because all we knew was this is probably a thrombosis which probably would increase and may lead to mesenteric ischemia and its related complications. So this patient was decided we would put him on therapeutic anticoagulation. He was put on enoxaparin 1 mg per kg body weight. So he was given 80 twice a day. And just to tide over this crisis, we thought it will be prudent to give him chemotherapy in the interim period so that we can halt the progression of the pancreatic cancer. Now, in our unit, FOLFIRINOX or modified FOLFIRINOX is usually a go to regime for downstaging CA pancreas, and we use it for borderline resectable CA pancreas. But our medical oncologists were not at all keen on giving FOLFIRINOX to this gentleman, because how it's going to interact in a COVID positive patient, we were not sure. So he was put on nab-paclitaxel plus carboplatin, and he received 2 months of chemotherapy. And during the same time, he was given a therapeutic anticoagulation. And at the end of 2 months, when we re-imaged this gentleman, to our pleasant surprise, the entire mesenteric vein has completely opened up. So there was no evidence of any thrombosis anywhere. There is no collateralization. It has just completely opened up as if nothing has ever happened to this man. And luckily, there was additional benefit that there was significant downstaging of CA pancreas as well. So it has reduced in size, though it was a resectable CA pancreas to begin with, but then probably it did help us in operating a morbidly obese patient, and there was definitely better outcomes. So this is an intraoperative picture, and this is the picture of the portal vein and the SMV, and it was completely supple. There was no evidence of any thrombosis or any collateralization or anything. So it was just a run-of-the-mill ripples that he underwent. Perioperative period was uneventful. We had to give him a prophylactic anticoagulation, which we usually start from day 1, but we were a little cautious in him, and we started his anticoagulation on day 0 itself in the night of the surgery, and which we continued for 4 weeks post-surgery. Now, what basically this case brings to our notice is basically how can we prove the association? Is it just an association, or was it a causation? So we don't know how to prove that. Was it a causation or correlation? But I think amongst all of us, we would have managed so many CA pancreas. I'm yet to see such a presentation in which CA pancreas leads to such a diffuse thrombosis of mesenteric vessels, mesenteric veins, not tumor infiltration into the mesenteric vein. I mean, this tumor was quite a fair way away from the mesenteric vein. So I think there is no way we can prove this association as such, but what we feel is the two hypocoagulable states combined together to precipitate this thing. Now, another issue was, should we be using prophylactic anticoagulation in such a patient? Now, tomorrow, if we find another CA pancreas or CA gallbladder or any other malignancy, and another patient comes to us and he turns out to be COVID positive or who had a COVID, should we be giving prophylactic anticoagulation to these patients? We still don't have any answer to this. I don't think literature discuss about this. I have done some fair amount of literature search, but I could not find any conclusive answers to that. And how long to continue prophylactic anticoagulation for these patients? In our practice, we anticoagulate all our solid organ cancers after surgery for 4 weeks. That is a practice that we follow in our institution. We always give them anticoagulation even after discharge for till 30 days, that is 4 weeks. For this patient, how long should it be given? So our medical oncologists were of the view that he's had this thrombosis, so they would want to anticoagulate him for 6 months. Again, we don't have any literature evidence to support one way or the other, but I mean, these are things that I mean, I thought it will be good to bring out to all of yours notice, and probably we can you guys can shed some light on this. So, I mean, I would just like to end with this quote that there are things known and there are things unknown, and in between there are doors of perception. I think there is so much of unknown entity of this going on. So probably you just have to keep our ears and eyes open and to see what we find in future. Thank you, Kalai.
Yeah. Thank you, Asit. That was really an interesting case, and also you nicely highlighted the points which we need to keep in mind when we encounter a similar situation in our practice. So I'll ask from other institutes, anyone wants to ask any question to Dr. Asit. So we also have Dr. Uday Koirala. He is actually from Kathmandu Model Hospital, surgeon from there. Welcome, Dr. Uday, for joining us. Because he's one of our institutes who regulate part of this JIPMER session. Yeah, I think we have a problem in hearing. Okay. Fine. I think we can have any questions from Dr. Saravanan and Dr. Ravi from UK.
Thanks, Kalai. It is a fantastic presentation, Asit, with focus on what we need to learn from. I think more importantly, I think this patient was very appropriately managed with a good outcome. And the two things which caught my eye, or as you said, is splanchnic vein thrombosis. I think you're absolutely right in saying that it's related to COVID. A couple of reasons I think is, one, it's so acute. Because usually malignancy related ones, you don't see that acute. And the second reason I think again is resolution with low molecular weight heparin is very unusual with cancer related thrombosis. So again, for that reason, I think it's more likely COVID related, which makes it more interesting, and it's very well managed, I should say. And that's what exactly we would have done as well, start the patient on prophylactic enoxaparin. And as you mentioned, we also continue for 4 weeks post-op. And in this case, I think I would agree with your oncologist colleagues that probably you should continue for 6 months, even though we think it's COVID related, but there's no harm in continuing for 6 months. I think probably the benefits are more than the risks involved. So on balance, I think it's safe to carry on for 6 months. That's my personal view. As you said, there's no data to suggest that, but very interesting case. Thank you.
Thank you, Dr. Ravi.
So just one question. So you are continuing with the low molecular weight heparin, or you are planning to shift to oral anticoagulants in case you are going to continue for 6 months?
Right now he's on, Kalai, he's taking his pending adjuvant chemotherapy sessions. So during that time, I think our medical oncology colleagues are more comfortable giving him low molecular weight heparins only. But now they are giving him a prophylactic dose, not the therapeutic dose like we gave at 1 mg per kg body weight. So they are just happy giving him 0.6 ml subcut once a day. So I think what we do typically is for the 4 weeks that we anticoagulate our patients, we keep them on low molecular weight heparins only.
Okay. Thank you, Asit. So I think, yeah, 20 minutes, so we are right on time. So we'll move to the next talk. So the next talk is from JIPMER. So the title is Robotic Revision Surgery for a Type 4 Choledochal Cyst. So let me share it. I hope my slide is visible. Okay. So we all know choledochal cyst is a congenital dilatation of the extrahepatic with or without intrahepatic bile duct, and usually associated with anomalous pancreatobiliary duct junction malformation. Type 4 is the second most common type after the type 1 choledochal cyst. So we all know the standard surgical management of type 1 choledochal cyst is complete excision of the extrahepatic bile duct with Roux-en-Y hepatococcygeostomy. While there's not much controversy with related to management of type 1 choledochal cyst, there's still some controversy with respect to the type 4A choledochal cyst, which have both extrahepatic and intrahepatic components. While the commonly used surgical procedure or commonly performed surgical procedure is the excision of the extrahepatic bile duct with hepatococcygeostomy, the same way which is done for a type 1 choledochal cyst. In literature, we have evidence that some of these patients come back with features of cholangitis related to the intrahepatic component. So what we are known so far, the role of laparoscopic choledochal cyst excision, we have a good number of series available currently showing the feasibility and also the safety. And recently, there are series which are focused on the robotic excision, which have again shown equivalent results, and also the suturing tends to be easier with the robotic, as is known for in other conditions also. But the role of the minimally invasive surgical management of the remnant cyst and the complications following choledochal cyst excision has not been very commonly reported. So what I'll be showing is the case in which we have done a robotic dismantling of the stricture duodenostomy and the Roux-en-Y post for type 4 choledochal cyst. So that's a case which I'll be showing, and the reason why we performed after the brief introduction about the case. So this is a 24-year-old female who presented with intermittent fever and abdominal pain for 10 years duration. She underwent open choledochal cyst excision and choledochoduodenostomy at 3 months of age. When she presented to us, we did an upper GI endoscopy, which showed strictured choledochoduodenostomy. And then we evaluated with MR and MRCP. So what we have seen is there were a dilated IHPR, but predominantly in the left lobe of the liver. So that's what being highlighted. So there is some pneumobilia, but the left lobe of the liver. Now here the question is, so is the symptoms are due to the stricture at the anastomosis? Because upper GI showed stricture at the choledochoduodenostomy, And then cross-sectional imaging showed evidence of intrahepatic cystic component, but predominantly what we are seeing is in the left lobe. And she had one more imaging prior which showed cholangitic abscess in the left lobe. So while symptoms could be due to the stricture choledochordionostomy, the fact that the changes are prominent in the left lobe of the liver might suggest probably the intrahepatic, the cystic components also contributes to the symptom. And that's the reason we decided we will, in addition to the revision anastomosis, we'll also do a left hepatectomy. So this is the port position. So we use 4 robotic trocars at the level of umbilicus, and then assistant trocar right at the infraumbilical region. So that's the trocar position. So because we use the XI robotic system, so we all know the XI robotic system, the trocar positioning is relatively straightforward. So the first step is adhesive lysis because this patient underwent a prior laparotomy. So So patient underwent a prior laparotomy. So there was intra-abdominal adhesions. So after doing the adhesive lysis, we use this round ligament for the traction on the liver. So once that is done, so the adhesions around the pericholecystic adhesions are being released. And as I mentioned, so this patient had recurrent episodes of cholangitis. So the changes were prominent on this, the left lateral segment. So because of that, the stomach was adherent to the undersurface of the liver, which is being released now. So that's a completion of the adhesive lysis. Once that is done, we did a cholecystectomy. So that's division of the cystic artery and then the cystic duct. So once that was complete, the bridge of tissue in the umbilical fissure is being divided. So that's the control of the middle hepatic artery, which was coming from the right hepatic artery in this patient. And that's next, the left hepatic artery is being isolated and then ligated. So once the arteries have been controlled, the portal vein is being dissected. So that's the left portal vein. Which is ligated. So once the portal vein was ligated, ICG was given to mark the line of demarcation. So after that, we move towards the division of the choledochordionostomy. So we dissected at the site of previous choledochordionostomy and then dismantle the stricture anastomosis. So this is the duodenal portion. And that's the duct, the hepatic duct portion. So we can see that's the duodenal end and that's the cyst portion. So we closed the duodenotomy using 3 OPDS sutures. So one important point when we do revision surgery for choledochal cyst is, in addition to the tackling the stricture of the anastomosis, so we also need to be sure that there are no remnant cysts distally. In this patient, when we did the MR, did not show any distal remnant cyst, but we wanted to be sure in TROP. So what we did was we did the cauterization and we dissected the periportal tissues. So the periportal tissues just showed some lymph nodes in addition to the lymph nodes, nothing much was, there were no remnances as was seen on the pre-op imaging. So that's the lymph node and there was no remnances. So once we are sure that there are no remnances, before starting the hepatectomy, we divided the left portal vein. So we use this, I mean, now that's being very commonly used in the liver resection is the rubber band retraction technique. Actually, we use a glove ring. So we don't have to sterilize the rubber band. So that's commonly available in OT. So that gives a stable retraction. And for the liver transection, we in robotic, we use mainly the harmonic. So the harmonic comes from the left hand trocar. So this first landmark is identification of the segment 5 hepatic vein. So once the segment 5 hepatic vein is identified, then keep following it till we see the segment 4B hepatic vein, which comes joined to form the middle hepatic vein. So that's a segment 4B vein joining with the segment 5 vein to form the middle hepatic vein. And once then the further dissection goes along the middle hepatic vein plane. So important point is follow the hepatic veins, and that's another tributary, probably the segment 4A vein, which will be coming and joining with the middle hepatic vein. Because we are using the harmonic and not QSO, so once and this is the division of the left hepatic duct. So once we have completed maybe half of the parenchymal transection, then we divide the bile duct at the intraparenchymal. So further dissection proceeds along the hepatic veins, and the left hepatic vein is divided using the stapler. So once that's done, go back to the infracolic compartment, identify the DJ flexure, and the ruling is prepared by dividing the proximal jejunum after the first jejunal artery. Then make a rent in the mesocolon to create a window for the rule limb to traverse to the supracolic compartment. So use a suture there, hold it with one of the instrument and place it in the cavity and then deliver the rule limb in the supracolic compartment. So we trim the edge and then the remnant, the anastomosis is done to the right hepatic duct and the jejunum. So usually the anastomosis is relatively straightforward with the robotic platform. Probably that's where you have the maximum advantage. So you use a 4O PDS for the anastomosis. So that's a completion of the posterior layer, and then the anterior layer is completed. So once the anastomosis is, the hepatic jejunostomy completed, then we complete the jejunostomy. And so that the staple entry site is closed with, again, PDS. And then hemostatic powder is attached, applied on the liver surface, and the specimen placed in the endo bag and retrieved. So just to highlight, and so the duration of surgery was 410 minutes with the 200 ml blood loss. The patient had an uneventful post-operative course and discharged on the 4th post-operative day. And she remains asymptomatic with a normal liver function test at 7 months follow-up. Thank you. So, any queries we can have?
Kalai, if I can ask a question out of curiosity,
Sure.
what do you think was the first surgery done where they left behind the gallbladder?
Yeah, that's what I think. Probably it must have been an inadequate cyst excision. So that's the reason we were specifically looking for the lower end. Because when we felt that gallbladder was there, that means the colorectal cyst excision may not be complete. But on MR, we didn't see any residual cyst. So definitely looks like an incomplete cyst excision, and they have done a choledochoduodenoscopy. Probably that is fine because most of the pediatric population still hepatic duodenostomy is being done. Yeah, as you rightly mentioned, the level of division looks much lower. Probably that also must have contributed to the stricture and the symptoms. Actually, we don't have the, we just had one line because it was done at 3 months of age. So that's the only record which is available to us.
Excellent demonstration.
Yeah, thank you, sir. We don't have any other questions. We can move to the next talk. So the next talk will be by Dr. Saravanan from Apollo Proton Cancer Center, Chennai. So he is a consultant GI surgeon at Apollo Proton Cancer Center, probably one of the centers in India with proton beam therapy. So he'll be talking on gallbladder polyp, malignant masquerade. Over to you, Dr. Saravanan.
Yeah, thank you for the kind invite. Are my slides visible?
Yeah, this is.
So I would present a case of gallbladder polyp where the final histopathology was unusual. I bring greetings from Apollo Hospitals, Chennai, from me and my colleague, Dr. Vaidishwaran. So as we are aware that whenever there is an imaging suspicion of a gallbladder mass or there is any atypical wall thickening which is not consistent with inflammation or cholecystitis, we always think about a possibility of malignancy. And in the southern part of India, where malignancy is not so very common, we also think about a xanthogranulomatous cholecystitis. In such situations, a conventional cholecystectomy is usually not preferred. And what is rather preferred is to do the cholecystectomy en bloc with a wedge resection of the liver if there is no significant liver involvement. Send that for the frozen section, and based on that, decide whether any additional resection in the form of a lymphadenectomy is necessary and margins need to be checked or not. So coming to the patient that we encountered was a 40-year-old gentleman who had pain in the right upper abdomen, which lasted for a little over a year. It was looking like biliary pain. There was no fever, no cholangitis. He did not have any weight loss. Examination was essentially normal. On ultrasound, there was a polypoidal mass in the gallbladder measuring about 3 centimeters. He underwent further cross-sectional imaging, which also revealed this 3 centimeter polypoidal lesion. It had a heterogeneous enhancement, some central necrotic component. On a PET scan, there was no metabolic activity which was seen elsewhere. So having encountered this situation, we decided that there is a distinct possibility of malignancy. So we should offer a laparoscopy and then do the cholecystectomy with a wedge of the liver. And then based on the frozen, we take a decision. This shows our port positions, which we used for the laparoscopic surgery. And what is essential is when suspected malignancy, the gallbladder should not be handled directly. So we used a gauze piece so that we do not handle the gallbladder directly. As a protocol, we usually always perform a Pringle, though in a smaller resection or a resection, it may not be always necessary. After that, the cystic duct is clipped doubly so that there is no spillage, which we are worried about in suspected malignancy. the cystic artery is taken. We do not approach and encroach into the cystic plate. This is the Pringle being applied. We perform the parenchymal transection using a Cavitron ultrasonic suction aspirator in the depth. For the skeletonization of vessels, larger vessels are clipped and divided. Superficial transection is performed with the help of harmonic shears. All along, it is important that the gallbladder is not handled and rather handle the liver while performing the transection. The rubber band technique, which Dr. Kalai alluded to, also is a good technique, which this was a little much earlier. Now we also have started using that. And also it is important when performing a liver wedge resection that we do not cone and come very close, especially as you come closer to the cystic plate. So it may be a good idea to keep looking in all directions, on the left, on the right, as well as the top. And especially if there is a suspicion of liver involvement, it is important that we do not cone on any side. This is probably one of the segment 4B branches draining into the middle vein, which was clipped. And as we come down, we will come to the cystic plate again, where we make an attempt to not go closer to the gallbladder. A very relatively bloodless field. Probably the Pringles also helped. We use a bipolar on the other hand whenever we encounter a bleeding. So that is probably the last bit, and the cholecystectomy with a good wedge of the liver is completed. The Pringles is removed, and specimen is then delivered in a bag. Hemostasis is confirmed. We left a Surgicel behind. Now, after completion of this, we sent it for a frozen section, and the frozen section was reported to be benign. So we did not proceed with any additional procedure. The patient had an uneventful recovery and was discharged on the third postoperative day. However, what came on histopathology was a surprise to us. The polypoidal lesion which was seen was an inflammatory polyp, but it showed very dense plasmacytic fibrosis, lymphoplasmacytic infiltration. There was a storiform fibrosis and obliterative phlebitis, which was consistent with the IgG4 related disease. And they did a immunohistochemistry, which is on the right panel, as you can see, which was positive, and to the tune of about 30 to 40%, so which is consistent with the diagnosis of IgG4 related cholecystitis. Now, as we know, IgG4 related disease, which initially was thought to be an organic disease, now the view is that it is more of a systemic disease where it has a preponderance to affect certain organs. More commonly, it affects the salivary glands, in the HPB, the pancreas, and lymph glands. Gallbladder involvement is relatively rare, and when it does so, associated biliary involvement is quite common. There have been various diagnostic criteria, majority of them coming from Japan, where they look at various imaging features. The histomorphological features that they characteristically look at are the obliterative phlebitis, the storiform fibrosis, and the lymphoplasmacytic infiltration. The serum IgG4 levels, especially the ratio of IgG4 to IgG, However, there are a certain distinct subset of a group of cases where IgG4 levels may not be elevated. Response to therapy also is considered one of the diagnostic criteria, where response to a steroid dose is helpful. The IgG4 levels coming down also tell us that it is a good response and it confirms the diagnosis. Usually steroids are needed for a period of about 10 to 14 weeks. And if there is biliary involvement, there may be a need for stenting during the treatment period. So when we looked at literature, there are about a handful of cases where IgG4 related disease is described in the gallbladder or specifically, and has necessitated surgery in most of the times, which means the diagnosis was more often subsequent to the surgery. It was not suspected preoperatively. So in retrospect, if we look at what was favoring malignancy and what was favoring IgG4, probably age was the only thing which was not fitting into malignancy. Most of the other features, a large polypoidal mass, the imaging features, and that there was no other organ involvement which is seen in IgG4, all that favored malignancy. So I don't think we would have done anything differently. So this was an extremely rare case of IgG4 related cholecystitis, where it presented in more of as a polypoidal mass. Most of the other cases, it is more of a wall thickening that it is seen. There was no other organ involvement, including pancreas. The serum IgG4 obviously was normal because it was checked post-operatively and there was no other disease elsewhere. It needed a surgical resection, and since complete excision was achieved and there was no other organ involvement, the IgG4 levels were normal. He has not been offered steroids and he has been asymptomatic at the end of 2 years of follow-up, keeping a close watch. So to conclude, laparoscopy in suspected gallbladder cancer, some important tips which we have learned from various series: not to handle the gallbladder directly, prevent leak, double clip the cystic duct, don't encroach onto the cystic plate, not to cone down on the liver wedge, and yes, send all gallbladder for histopathology. In IgG4 gallbladder specifically, biliary involvement is known. We've had another patient who had developed biliary involvement much later. So that is very, very important to observe for. And with that, I conclude my presentation. Thank you.
Yeah. Thank you, Saravanan, for the nice presentation. Again, an interesting case. Yeah, definitely. I think this IgG4 related disorders, now we tend to recognize at least frequently, because that awareness is there, especially among the pathologists. Once they find some clues, they tend to do that, and we are seeing relatively now more than what we have seen before. So one important point, as you highlighted, is it's more of a systemic disorder with organ-specific manifestations. The important point to keep in mind is, I think they are at risk of the malignancies elsewhere. So that's one thing, probably, as you mentioned rightly, they need to be under follow-up, and we need to be aware that they are at risk of, like, for example, if you are seeing in the pancreas, actually the deaths are more with the extra pancreatic malignancies rather than malignancies within the pancreas. Even I think I can ask Dr. Aziz also to comment. Probably he also had a series of this IgG4 related disorders. He once presented, probably, I'm not sure it's published also.
Yeah, Kale, I mean, we managed to publish a couple of papers on this. This was during my stint in ILBS. So we had experience of managing IgG4 related disease isolated in gallbladder. What Saravanan has shown, exactly the same presentation, but our case had much more of liver involvement. So our suspicion of malignancy was much higher. So he underwent a radical cholecystectomy. We didn't send it for frozen because we had a suspicion of malignancy too high. So it came out as a post-operative surprise for us. But once we became, like you said, once we became aware of this entity, we managed to diagnose a couple of patients pre-operatively and avoided surgery altogether in those cases. and we had a couple of presentations with our pathology colleagues on in this aspect. So, like you said, yes, this is an entity, and they call it a new age chimera, which is more and more becoming apparent to us. But what Dr. Saravanan said is very important. Like, you might find one or two odd cases in your career of such a presentation, but we must not get carried away with this. Still, especially when we talk of North India, malignancy of gallbladder is so more common for us to see that we rather err on the side of offering them a radical surgery rather than undertreating them and later on getting up in a mess. So yes, a wonderful case, and I would compliment Saravanan on the beautiful surgical technique that he has shown. I think there was hallmark of GV Pant all over there.
Thank you. Thank you. I resonate with your thoughts. Actually, there was this another case which we had. So the flip side is we should not overdiagnose IgG4 and miss out malignancy. So we had this gentleman who had been diagnosed as a cholangiocarcinoma. Unfortunately, it was not resectable. There was extensive bilateral involvement, some vascular involvement as well. And the only thing that we could have offered him was chemotherapy. So they wanted a tissue diagnosis. So we did a biopsy, and what came out was IgG4 disease in that. So since so we told him it could still be malignancy because cholangios are notorious. It will not to get a tissue diagnosis is very difficult. But we did give him steroid. His IgG4 levels did come down for a while, and since he anyway did not merit surgery, we kept him on a close follow-up. He developed portal hypertension because of the extensive vascular involvement, and that also has been reported that you have IgG4 related disease with vascular involvement has been reported with producing portal hypertension. And with portal hypertension, we thought, is there still a possibility that this is not cholangio? Malignancies will not usually proceed so slowly, but yes, sometimes it can. Finally, this patient did progress, develop some more lesions, which when biopsied confirmed cholangiocarcinoma. So yes, it is, we should not, on the flip side, overdiagnose and miss this, because sometimes IgG4 may not be elevated, maybe in the border zone, and the storiform fibrosis is not characteristic. There can be a pathological bias on that as well.
Yeah, I think that's another important point was even when you see, because there was one case in which actually there was a combination of both malignancy and the IgG4. So even when you diagnose IgG4 pre-op, so whether you should, I mean, just label it as IgG4 disorder. So always look for evidence for malignancy because they do coexist. So that's another point also which we need to keep in mind, especially if you are trying to make a pre-op diagnosis and going to manage that based on the pre-operative diagnosis. So a lot of important points have been discussed. Any other questions, or we'll move to the next talk. So we have the next talk. So I profusely thank Dr. Ravi actually, who readily accepted our invitation because he's in UK and it's early morning there. So he started, he joined us at 5:30 a.m. UK time. So thank you, sir. So I welcome Dr. Ravi Maruthanayagam. He is a consultant HPV surgeon at University Hospitals, Birmingham NHS Trust. That's Queen Elizabeth Hospital, Birmingham, UK. And so he is, yeah, he's actually the lead surgeon who developed the minimally invasive program at the University Hospitals. So it's a pleasure to have you here, sir. And he'll be talking on the techniques of laparoscopic right hepatectomy. Over to you, sir.
Thank you, Kalai, for organizing this and inviting me. Can you see the slides, please?
Yeah, we can see it.
Okay, thank you. There may be a bit of a lag, actually, especially with regards to the videos, but I apologize for that. Please bear with me. So I'm just going to focus on the techniques of laparoscopic right hemihepatectomy. and I'll give some tips and tricks at the end of the presentation. That's the positioning of the patient, which I normally use. Usually use a French position. As you can see, there are assistants on either side, and have a header position that would definitely help prior to parenchymal transaction to reduce the venous pressure, and keep a saline bag to the right behind the scapula. The other option is to tilt the patient to 45-degree, and some of them even do in a left lateral position. But I would prefer to use a saline bag and use tapes on over the chest and over the groin, and tilt if you need further tilt. And as you can see, the positioning of the instruments and the energy devices. So the problem with laparoscopic resections are you've got far too many gadgets around you, and the wires can keep getting entangled, and you can get frustrated. So it's very important that these are all positioned appropriately prior to the start of the surgery, so that you don't encounter disasters during surgery. So these are the ports I use. I prefer to use all of them 12 millimeters for the simple reason that I can interchange the instruments, so that I don't have to convert a 5 to a 12 halfway through the surgery. I used to start with a midline camera port before, but I find it more convenient to move it slightly towards the right side, although it can be a bit challenging to get the first port in. And then, so that the lateralmost port goes well to the right, and it helps in mobilizing the right lobe of the liver. And the top ones, I use it for hilar dissection. It's far more convenient than from doing between the legs. And it can be used for dynamic retraction, which I'll show you in the video. So these are the instruments to be kept ready for a major hepatectomy. And if any new centers are planning to start laparoscopic liver resections, so these are the gadgets you need prior to undertaking any major resections. So clearly you need an intraoperative ultrasound as in open. Then the right angled dissector, it's very useful instrument for hilar dissection. And the diamond flex retractor. So this, I use it as a dynamic retractor. This helps really to mobilize your right lobe with the right hand through the epigastric port while you're dissecting the right triangular ligament with your left hand. So it's a very useful kit to have. The next one, Endoflex. This is my favorite instrument. This, we call it a bendy Johann. So it's basically a Johann retractor, but with a bend at the tip of it. It's very useful, again, to get to the hilum, for Pringle, and for the right hepatic vein. So essentially, it has got a opening tip, and you can grab tapes and threads with that. And you can as well bend it, and you can fix it at whatever angle you want it. So it's a very, very useful instrument to have. Vascular clamp, either a bulldog or a long vascular clamp for any major procedure, vascular procedures, hemolocks, staplers. So just to go back, sorry. So the other ones, energy devices. I think there are plenty of energy devices available of late. The couple of them which I like to use are definitely a bipolar, standard bipolar forceps, and also a ligature, which helps in dissection. Then the retrieval bags and the hemostatic agents. Again, you've got plenty of options available now. So this is a video of an edited video of lap right hemihepatectomy. This is quite early in my career when I started. So some of the techniques may be slightly outdated, but I'll keep you informed as things go along. So the first step is division of the falciform ligament. So when you go up, it's very key that you go all the way up to the top and dissect to the extent where you can see at least the middle of the right vein. An intraoperative ultrasound. So give plenty of fluids to check for the ultrasound. The next step is the cholecystectomy, the cystic artery. And that's cystic. The most common indication we do a right hemi here is colorectal liver metastasis. And the next one is the HCC. So predominantly it's colorectal liver mets. So that's the highlight dissection. So this is the crux of the operation, to identify the right artery, the right vein. So it's very important that you delineate the artery very clearly so that you don't inadvertently take the left artery. So anything to the right of your bile duct, you can safely assume it's a right hepatic artery until proved otherwise. So in this one, as you can see, there's a tilt there's a hunch of the artery going to the left. That's what initially I thought, but further dissection, I realized it's taking a turn and going towards the right side. So the next one is the dissection of the portal vein. The hook is a very, very nice instrument to do the highlight dissection, but again, keep the power very low to 20 or 25, preferably without spray on pinpoint. And I tend to even dissect with a hook, so it's relatively safe in experienced hands. And then you get your hand to dissect it further. So this is where I said the right angled instrument. It's very handy. That's a right portal vein. And in fact, you can see the left portal vein coming off there, but it's always worth doing a trial clamping just to make sure that you're not hinging onto the left side. That's where the vascular clamp comes handy. This was, as I said, very early on in my career. We didn't have a bulldog at the time, so we do have bulldogs now. So again, sometimes you may not see the demarcation just with the portal vein. You may have to clamp the artery as well, but thankfully in this one, just with the clamping of the portal vein, I could see the demarcation well. So the right artery is going down. And then the right portal vein. Unfortunately, the first clip didn't go, even though it went across. I wasn't happy that it's gone all the way through. So change my angle from the left side. So again, key point is to clip it one after another to divide it. Otherwise, if you clip the artery early on, it can keep coming in your way. Again, before you clip and divide, make sure you've got good length of the artery in the vein. Otherwise, when you're dividing the bile duct with the stapler, the hemlock can keep coming in your way again. This is mobilizing the right lobe of the liver, dividing the right triangular ligament. This is what I was saying. You can use the endoflex and use it to retract the right lobe nicely while you're dissecting with the energy device with your left hand. So I used to use Lotus, but the harmonic is very good as well. The harmonic A's, the harmonic HD. Again, as you go to the top, your hook diathermy is a fantastic instrument to have. Then coming to the short hepatic veins. So when you do this, sometimes it's useful to have an infraumbilical port to view from below while you're dissecting with the ports along the right side. Or you can just use the standard ports, which I showed you earlier on. Again, ligature is a good instrument to have to just take this down without clips. Again, when it just started, I used to start clipping all this to become a bit more brave and just take it down with the ligature. But some of them, like this one, definitely need clipping. So you've got 5 millimeter hemlocks as well. So you can use those ones for the short hepatic veins. And keep going up to the top. As you come towards the right hepatic vein, it's important you do it from both directions, from top and from the back. So we've gone to the top now, we're dividing the rest of the peritoneal attachments completely. The important landmark to here have is the is the diaphragmatic vein. So you can use that to see where your right vein is going to be. So now coming on to the Pringles. So this is the one I was mentioning earlier on, the diamond flex, which is very handy. So you can see it has got a opening at the tip. You can just grab it and pull it across. So I use a 24 or a 26 French drain tube and bring it through one of the ports by the side of the port so you can control it externally. So you can see the demarcation quite well now. The Pringle is not on yet, so you can see the demarcation well. Again, it's very important to do the marking, because once you start the transaction and if there's a bit of bleeding, you can easily lose track and go into the wrong side. And that's the caudate. Again, caudate always tends to bleed because you're not devascularized the caudate. It's still got its blood supply. So the first 1.5 to 2 centimeters, you could essentially do it with the energy device, either harmonic or, as I said, I was using Lotus before. But these all instruments are all good enough to transact the first 1.5 centimeters to 2. So again, it's very important to use both the hands. So I just slightly speeded up the video here, which is a bit distracting, I'm afraid. Beyond a couple of centimeters, it's very important to use the Kusa, and it's again a good technique to use Kusa both hands, and make sure you clip all the small veins across. But definitely the segment 5 and 8 vein needs to be clipped either with a hemalock or a stapler. But these small ones, you can clip it or use even a ligature to divide them. So the Pringle is on now. So as you can see, it's good to have all the gadgets. And the key thing is to use Kusa on one side and the ligature on the other side. And sometimes the ligature may not be good enough. You will have to use the bipolar to divide it. So this just want to show the use of bipolar here. So as you can see, I was trying to control with the ligature. Quite difficult to get hold of it, especially if the vessel retracts back into the parenchyma. Then your bipolar is very handy. So now coming to the hilum, so I always take the bile duct inside, as I'm sure is general practice everywhere. So the artery and vein outside, and the duct always inside the parenchyma. So that's the right hepatic duct, which is stapled off. One of the problems we encounter here is high BMI patients, unfortunately. So that's the segment 5 vein. As you will probably see that while putting the clip, it just tears a bit and it bleeds from the middle vein backflow. So just putting the clip, there is a hole on to the right of it. Just trying to, you can see that hole clearly. So the key thing is not to panic, increase the intra-abdominal pressure or reduce the thoracic pressure, and try and get it, or sometimes you can use a bipolar device as well. So thankfully it got controlled with another clip. So this is again important trick to have, to put your hand below and lift it up. That helps to achieve the hemostasis. So some of the bleeding points need suturing then and there. So basically only thing you're left with now is your right hepatic vein. So that's the right hepatic vein. which is stapled off. Again, always check before you divide, because it's easy to go to the left and sometimes take the cava. People have done it. That's a specimen out. And we use the standard endocatch too for big specimens. And the important thing is bile stasis. Again, put a Pringle on for a few minutes to look for any bile leak. That's a very handy procedure to know, technique. And just suture any bile leaks. And hemostasis, I use a combination of something called Avicel with the Fibrillar on top of it. I'm sure one of them is good enough, but it's so that I can have a good night's sleep. I use both of them. It's important to fix the falciform so the liver doesn't rotate, even though you're not mobilized the left triangular ligament. So that's a drainage. So just a few tips and tricks with regards to lap right hemi. So the key thing is to identify the groove between the right and the middle hepatic vein, because as you divide the falciform ligament, so when you divide the falciform ligament, it's very easy to go in this plane, and you may end up to the left of the cava. And this is very important, especially in very slim individuals. Your cava is very narrow. You just think that's right hepatic vein. It's easy to clamp it across. So it's important that you grow, as you divide the falciform, start going towards the right side. And then you need to identify the middle and the right vein groove so that you don't make the mistake of going to the left of the cava. The next tip is after division of the cystic duct, you can keep the gallbladder in for traction. So as I said, this was an early video, but now what I tend to do is divide the cystic duct, peel the gallbladder to one side of it, just half of it, and use it for holding it as a counter traction. You can use it either for the left or for the right, whichever you think where you need it more. I tend to put it on to the left side so that you can just pull it on the left side when you're doing the transaction. And again, it's a good practice to have the cystic duct stump long. And especially if you're using a tie, you can use a long tie and leave it longer to do the rest of the highlight dissection. Because what happens once you divide the cystic duct, your cystic duct and the artery keeps falling onto your field when you're dissecting the artery, and especially the portal vein. So if you're not using a tie, just leave the stump long and hold the stump long. And then the port on the left side, you can use it to hold it and retract while you're doing the rest of the dissection from the epigastric port or even from between the legs. The other thing I mentioned is dissect adequate length of the artery in the portal vein, because when you're transacting your right hepatic duct, it keeps coming in the way otherwise. So the other option is to use a tie completely and without using any clips, which I find it a bit scary, but probably with time I'll start doing that. As I mentioned again before, better to have some 5 mm hemolocks for short hepatic veins. And the diamond flex is a very, very good instrument to have. Then, so again, the Pringle, where you bring out the snugger is important. So if you're doing a right hemi, bring it onto the left side. If you're doing a left hemi hepatectomy, bring it onto the right side. It gives you countertraction by itself, apart from providing Pringle as well. Mentioned before, energy device for the first couple of centimeters. So the Kusa setting is very important. So I've learned my own way. So this is the setting I use. For suction is 70, irrigation is around 4, and amplitude is around 50, and tissue select, again, 1+ or 2+. So with this setting, pretty much most of the liver you encounter, post-chemo liver, fibrotic liver, you can essentially manage. It seems to work well for me. Again, the lap, I may or may not use it, and I'm not using the lap one because your suction is very low. It can be a bit frustrating at times. So without lap and with the diathermy at the tip, it's a perfect instrument to have. So the key thing for right hemi hepatectomy is not to panic. You just only have basically 4 major structures you're going to come across. One is your inflow pedicle, your segment 5 and 8 vein, and your right hepatic vein. So most of the other structures, you can pretty much take it down with small clips or with a ligature or with the energy device. So have both bipolar and the ligation ready. Ligation is good when you can see the vessel, while bipolar is useful when the vessel retracts back into the parenchyma. And avoid organ, even for minor liver restrictions. Don't use organ, because there are case reports with organ embolization, especially with cardiac surgery, and a couple of liver cases have been reported. So it's better to avoid completely organ coagulation. Then again, it's a good tip to have to look for bile leak at the end of the operation. Just Pringle for a minute or two, and then check for any bile leak. That way, even though it's not physiological, but it helps to identify any tiny bile leaks, which could prevent problems post-op. Thank you.
Yeah, thank you, sir. That was a very wonderful talk, especially focusing on the important steps, and the tips which you have given are really useful. So I will start with a couple of questions before moving to others. One is the Johann Fosse, which you have mentioned. So that looks more like a Goldfinger dissector, right? So
it is similar to Goldfinger.
Okay.
You mean the one which I used for the Pringle one?
Yeah. No, you mentioned one is a diamond flex. The other is a. So can you just go back to those instruments slides?
So this is the diamond flex.
Okay.
So this comes in different forms, isn't it? You have the pretzel, which is like even more wide.
Yeah.
So this one is the endoflex. This is what I was mentioning about. I think Goldfinger, you don't have opening and closing at the tip. I think.
This has an advantage. You can open it and
grab it. We used to use Goldfinger before, but then you have to thread at the tip where the groove is. So it can be a bit challenging, especially if you're doing the right hepatic vein. But this one is quite handy. Once it's in, then you can just control from the bottom here. So there is a rotating wheel there. So you rotate it and then lock it with this. Then it stays in position wherever you want, and then use this to open it up. And then you can just grab it and then you release this and then pull it back.
Okay, so this is from which company?
Good question. I don't know. I need to check, and then I can let you know. Actually, yeah. Sorry.
Because that looks like a useful instrument.
Definitely. Actually, we used to struggle with the Goldfinger before, especially the right hepatic veins. I used to isolate extrahepatically before, but now I take it intrahepatic. But even if you want to do it extrahepatic, this is a fantastic instrument to have.
And regarding the trocars which you have shown, I mean, maybe we can just go to the previous slide, the port positions. So, so you mentioned that the Pringle will come out of close to the left trocar.
Yeah.
And so you keep the long drain. The drain also comes out of the skin.
Yeah. So the long drain comes all the way out by the side of the port.
Okay.
So your port is still usable.
Okay.
But so what you do is you keep the port in, get your Johann through the drain first, outside. Okay. And then you take all the way in, you hold your tape and pull it out. So it's inside the tube now. And then push the drain in all the way inside through the port, then take the port out, and then reintroduce the port by the side of the drain.
Okay.
So you got your Pringle drain coming through that port, but it's by the side of the port, and the port is still functional.
Okay.
So, but don't inflate the balloon of the port, because I use all balloon ports. But if you inflate the balloon, then it's difficult to get the Pringle control. So this port alone, don't use the balloon on, so that you can slide the tube in and out quite easily with the Pringle on. It's much more easier to control from outside. Again, I used to use, when I started Pringle from inside, I used to use a Hemlock to Pringle it, but taking the Hemlock out is extremely fiddly, and we used to burn with the diathermy, all sorts of things actually. So, and then I tried the technique of where some of the Europeans still use, where you hitch the drain against the abdominal wall, where you push it and then leave it against the abdominal wall. But there are a couple of problems with that. That pressure may not be adequate to control your arterial pressure. The pressure, it won't be that high. The second thing is, you have to get the exact length of your tube so that it can hitch against the wall. Against extremely variable from individual to individual. So this one I find it the most useful and easy to use. Just bring it by the side of the port. You're not losing anything. Your port is still there, and it's much easier to control from outside.
Okay. Because we commonly use just place a clamp, vascular clamp, and then release it. Or recently use a Foley's. Foley's you just, I mean, there's a eye at the tip. So through that, you bring the other end out and then you tighten it and loosen it. So never tried this method. So just want to know like exactly. So, and doesn't cause any air leak. So you clamp it when you're not using it.
No,
That
yeah,
you,
exactly.
okay. Yeah. So do you
we use air seal. I don't know if you have what's the equivalent of that. I don't know. We call it air seal, which is quite good. It measures your intra-abdominal pressure. I think 60 times a minute or something. It's pretty good. So we don't have any problems with the air leak so far, but you're still clamped anyway on the tube outside. So
you have questions from other centers?
Dr. Ravi, if I can ask you something, what are the challenges that you face during a laparoscopic resection in the caudate division part, and what are the tricks to go about it?
Yeah, caudate is always a problem. So the earlier you tackle, the better. So when you mark with the diathermy your line of transactions, it's important to get where you're going to divide on the caudate, and it will bleed. So there is no way to prevent that because your caudate is not devascularized, unlike your right lobe. So it does bleed. So it's important to use the energy device liberally there, especially the bipolar and your harmonic device. So don't go too far. So divide probably for a couple of centimeters. So you know where your landmark is. So then when you come with the CUSA anteriorly, once you have come to your hilar plate, you know where your bile duct is going to be. So again, it's very important you stick to the plane where you have initially marked. What tends to happen, we tend to be overcautious and start drifting to the right side. So when you start drifting to the right side, you are dividing your right vein at your anterior posterior sectoral division. So it's very broad and your staple doesn't catch. You know? So it's very important you stick to where you've initially marked. So that's why the initial mark is very important. You see the division of your right vein. You see the liver end, you see the main portal vein end. So your line of transaction has to be exactly between that. So you know that what you're going to catch is only your bile duct there. So when you start dissecting with the CUSA there, you come to that plane, then you start dissecting the caudate from behind with the CUSA. So there you can be a bit bold at the time because you know there's nothing going to be there. It'll bleed a bit, but that's fine. You're going to catch it with the stapler soon. You know? So then you just liberally use the CUSA with the diathermy. That's where I found the CUSA diathermy extremely useful. To use the diathermy on the CUSA, use both simultaneously. So it keeps burning those tiny vessels and has a good hemostasis. So then you can just fire the stapler straight after that.
Right. Dr. Ravi, I mean, you mentioned one thing about your positioning. You said you do the entire procedure in the French position. Don't you think doing the hilar dissection would be a bit easier if you do it from the left side of the patient? I mean, what's your
no, exactly. You're absolutely right. Because I started with doing the hilar dissection in the French position. Just nightmare, even to take the gallbladder out. No? Your shoulder aches and you're shouting, screaming at your assistants, and you're in the wrong angle. So with time, what I realized is I start from the French position. Then for hilar dissection, just move on to your left, and it's much easier. Pretty much like a gallbladder. No? You're just doing like gallbladder operation. Your hilar structures are much easier. The portal vein can be a bit tricky. So you may have to come down to the French position for the portal vein sometimes. So, but the artery and mobilizing the structures to get to the portal vein, it's much better done from the left side.
Yeah. So I mean, so if you have to summarize, so hilar dissection from the left side, and the liver mobilization and the parenchymal transaction from the French position between the legs, right?
Yeah.
If I'm not wrong.
Yeah,
perfect.
Exactly. Yeah. So I think parenchymal transaction again is very important to get the ports right. You know, so because your CUSA comes from one side or the other side, it's never in the middle because your camera's in the middle. So you've got the CUSA either coming from the left or from right hand, which is a bit awkward. But having said that,
if you don't mind, can you show your port position again? And when you're describing this, I mean, this is not how I would do it. I mean, so I'm finding your port position very intriguing. I mean,
so the idea we started with this is if you have to convert to open, it's just nice to convert like that. No? So we're trying to follow the same one, but the left I use a slightly different one. So this is through your rectus sheath and the rectus muscle in the post sheath. This is slightly towards your lateral end of the rectus, a bit more even laterally. And this is further down, almost below the right rib cage, almost to the anterior axillary line, because the patient is tilted with a sandbag on the right side. And I still give a tilt of the table as well when you're mobilizing the right lobe.
Right.
So I've tried various different positions, port positions before, but this is the one I found it extremely comfortable doing with now. For the left, I use slightly different. I use these three, but I put the two here actually. It's almost like a wide V-shaped one. But for the right hemi, this seems to work for me.
Thanks.
But some of my colleagues use a completely left lateral position to do the whole right hemis. Can be a bit tricky to do the hilum. I know some of my friends from Oxford, they put it completely left lateral, and I still wonder how they do the hilar dissection, but they seem to like it because the mobilization is so easy. I think you need to have a different perspective of the whole view, especially if you're doing regular adrenals. That position works well because you're used to that view all the time. I don't do adrenals, so it's a bit tricky for me to have that view. I can get lost. I'm happy with this one.
Okay, so we are on time. We are supposed to finish at 12:55 IST the talks, so we are on time. We also had, we have another network called BIMSTEC, which involves our neighboring countries. So we have actually Dr. Kip Chu sharing from Bhutan and Dr. Uday Koirala, who are part of our BIMSTEC network, so from Nepal. So we thank them also for joining today. So we are actually almost ending the session, so we could not have much time interacting with others. So first of all, I thank all the speakers for taking their time and in spite of the busy schedule and also the odd timings with some of the centers. So my profuse thanks to all the speakers. And I also thank the participants from Nepal and Bhutan. Also thank all the institutes who are joining us through our YouTube live streaming. I hope you had a good academic session. I hope you would have learned some of the tips and tricks in the advanced GI surgical procedures. So once again, I thank everyone for being part of this wonderful session and this APAN51 JIPMER session on advanced GI surgery. Thank you.
Thank you, Kalai.
Thanks, Kalai. Thanks, Dr. Ravi. Thanks, everyone.
Thank you. Thank you, everyone.
Thank you.
Thank you. Good to see you in the next meeting.
Yeah.
Thank you. Bye.
Bye. So we'll end the, Vishak, we can end the